Purdue, if you could start training, start recording at this time, that would be great.
It should be going.
Great, thank you. So this was definitely teamwork on this presentation. So I want to thank Erica and Bonnie and Kelly and Korina, as well as the whole state team staff of just giving input and direction and helping out today as well. So we have facilitators in breakout rooms, as well as state staff taking notes. So thank you. With this presentation, we are hoping to dive into risk assignment in WIC. That is something that I always thought was set both in terms of the description of the risk and the risk level at the USDA level. So this has been an interesting learning process for many of us at the state as well. We want to share that with you. We also want to look at this functionality of professional discretion high risk and what it can mean for dietitians and breastfeeding experts in Oregon WIC. We want to have you give input to the process and what it looks like in our new data system, which is called Otis. And then start to be thinking about what this looks like in the clinic and in clinic operations, and how we will engage WIC staff to implement this tool that we have coming up in Otis. So with that discussion, it is helpful to look at some key foundational considerations. The WIC system, Otis, is under development, and for those of you who went through the development of Twist when it came about, data systems are complicated, and especially when you work in Oregon WIC, where a lot of developers are not accustomed to how state staff, both local agency staff and state staff, work to give input and testing and training, and that whole user acceptance testing, that UAT is much different in Oregon than other states. So we are unique on that way. And as you have heard, the timeline for the rollout is a moving target. And with that, part of the reason that it's a moving target in terms of when the rollout will be is that Oregon did not simply take a product off the shelf and just implement it. We customized it to be able to have things like an auto scheduler, or having farmers market built in, that we want a lot of the elements that we have in Twist in this new data system. As such, certain elements that we wanted, such as dividing out risk 201, which has kind of the high, that is the one risk that we have to change, as you know. We wanted it to be done behind the scenes and not have to have staff make that change. That's gonna take some time, but we are still working towards that goal. So today we really want to have an opportunity to focus on how we can promote WIC nutritionists and breastfeeding experts through using the professional discretion high risk. And this is all new for us too. So we have not been able to get into the testing database for some time, and we won't be able to for some time, and that's very frustrating. So some of the screenshots that we have to share with you are from design documents that we were able to access. And I know it's like this little glimpse, and you probably want a whole lot more. And so I ask for your kind of flexibility and compassion with us as we dive in. And we really want to hear from you, because you are the experts for your agency, and you know how these things will work the best. We encourage feedback both today in the session, but if you need more time to think about it, reflect about it, it's totally fine to give us feedback via email as well. So to get our mind kind of wrapped around all of this, it would be helpful to use a warm-up activity. So whether it's just writing down on a piece of paper where you're at, or putting it in a chat, Here's a question for you. Think about a time when a WIC staff person referred a participant to you that was not high risk. It could be that they scheduled that person with you. It could be that it was a hallway chat. They picked up the phone and called you. Just think about those times that they may not have, they were not high risk, but they had concerns, issues. So if you could just put in the chat just what those issues were, and we'll just kind of keep going, but just kind of get you thinking about what are times that you have had individuals come up to you and like, oh, I'm really worried about this person. What was that issue that they were concerned about? Feel free to put it in the chat or just write it down next to you so you can kind of start thinking about it. Okay. Now, as you're putting them in the chat or thinking about that, I'm going to pass the slides over to Erica to talk about an overview of Oregon WIC nutrition risks. Take it away, Erica.
Hey, how is my audio sounding?
Oh, really great. Thank goodness.
Perfect. Okay, great. Yeah, so just an overview, just when thinking about our Oregon WIC risks in general, we have 100 current nutrition risks. And for Oregon specifically, 28 of the risks are high risk. And that 28 includes risk 201, which we know sometimes people are medium risk with that, but sometimes it's elevated to high with very low hemoglobin. And one thing that's really great about this PDHR, professional discretion high risk function that we're talking about today is that it includes also the local agency breastfeeding experts. So with high risks, those are referred to the local agency dietitian, and this PDHR feature can be a way of also including breastfeeding experts as the one to make the referral for when we have this designation. So risk level is determined by each state or region. So that is something that I've definitely learned coming into this position and kind of trying my best to step into Vernita Reyna's shoes as the nutrition risk queen, figuring out how we do things and how the risk information comes down from the federal level. And essentially they set the parameters and the numbers for each risk. And so they set like the subject of it, what that risk can entail. And then at the state or region level, that's where the risk level is assigned. So yeah, so we have some flexibility and some choices to make when it comes to risks and risk level. Next slide, please. So one thing that I've done to just begin this process, and Cheryl was a big help with this, is asking other Western region partners, so other states or regions within our Western region cohort, what their risks are that are high risk or not. And so I started by sending a spreadsheet of the Oregon high risks and then asking everyone to fill in what theirs are. And it was very interesting to see the comparison. So there were many similarities between Oregon and the Western region partners. There also were some differences. Some of the partners choose to have several of the risks broken up into at risk of and then the actual risk. So like at risk of underweight or at risk of overweight, and then that being different from overweight or underweight on its own. And in Oregon, we combine quite a bit of those. And so that was one difference. And using that comparison of risk levels is part of what we're doing to inform our process for PDHR and kind of look at maybe what some other risks that are high in other states or regions, maybe those are some good risks to focus on when we're training on PDHR or kind of introducing this concept to all WIC staff. Okay, and so in TWIST, we've been used to having high, medium, and low risk. And as we change to OTIS, it's really just going to be 2 levels. So there will be high risk, and then the other level, we don't really have the official way that we're going to refer to it, but at risk is kind of how we've been talking about it lately. So yeah, just those 2 levels, high, or at risk. And we are going to enter into some small groups for a discussion now. And this discussion, we're going to be talking about just kind of if you had any sort of reaction to what I've just shared and kind of how risk level is determined, and then also thinking about risk levels and if there are any risks that you either wish were high risk and they're not, or that are high risk that you're kind of like, oh, why do I always get referrals for this when it's not necessarily something that there's a high risk intervention for. So we are going to go into those rooms. There will be a facilitator in each room, and then we'll ask to have someone be the person that will report out, and then there will be a state staff member taking notes as well.
Thanks, Erica. And Laura Perdue will be putting us into groups, and we will have 2 breakout sessions today. So we're trying to keep the groups to the same individuals in both breakout sessions. If you have handy the job aid that was sent out prior to this meeting about risk levels, that will be a good reference for you. If I can try to see if I can put it in the chat. I have a harder time with Zoom than I do in Teams of putting things into the chat, but we'll work on that. I think we can just link it right to the website. Laura, you ready?
Yes, I'm ready if you are. Cheryl, I can't assign you to a room since you're a host. So if you can move yourself to room 6 when I open the rooms.
I will do. And just so you know, we have allotted 12 minutes to be in the room, so there will be time to do introductions amongst it. There may, and feel free, this is share as much as you're comfortable with. If you want to just kind of listen in, that's fine too. But we are ready to go. Erica, thank you for picking up the job aid that is in the chat.
Okay, I will open the rooms. If anyone has any issues, you can chat me, Laura Perdue.
Is being recorded.
Okay, I'll bring up the slides again. That went really fast.
It went really fast.
It was, yeah, it was very fast. Yeah, and even though I said that we would designate someone to report out, I did not even do that in my room. So
Yeah, that's okay. That's always a hard one.
yeah, I'm not sure if there's anyone from room 2 that will want to jump in, but yeah, so would love to hear, get a little glimpse of some of the conversations in each of the rooms. So maybe starting with room 1. I'm not even sure how many rooms we had. Laura, how many were there total?
There were 6.
Okay, awesome. So does anyone want to share out a bit from room 1?
Group 1 was my group. Does anyone want to share anything out? I guess I can share that there was general surprise that the risk levels were determined at the state level rather than the federal level. We had a couple of people in our group that were from other state WIC programs, and so they could see some slight differences in terms of the risks. And then they We didn't have a lot of time for the risk codes we wish were not high or the ones that we wish were high, but we did hear about other medical conditions, high weight gain in pregnancy, both wishing they weren't high risk, and then the breastfeeding ones, 602 and 603, wishing they were high risk. Also, let's see, 151, which is small for gestational age. And thyroid disorders, wishing they also were high risk. So, and that's
Great.
it for group 1.
Yeah, that's great. And then group 2 was my group. Is there anyone that wants to share, or I can also share a little bit? Well, for the sake of time, I'll just share a little bit. So, yeah, we talked about a little more about the process of comparing risk levels with the different areas, and just how that would be interesting to kind of like see where we're at and what other states do. There were some ideas for risks that could potentially go to high, and we also talked about how there often is quite a spectrum represented by one risk. And so like there was the premature birth, and that, you know, that one can really vary in weeks of gestation. And so we talked about kind of on those spectrum ones. That's one reason why as the state staff, we're really excited about the potential of PDHR, because that can kind of help really make it so that people don't fall through the cracks. And then there was a bit of discussion around the risk 303 and 304, history of gestational diabetes and history of preeclampsia, and kind of concern for those being low risk, because sometimes though the history of that can be missed in regular prenatal care, and can just be things that we can follow up on. Beth, anything you want to add? You were also in there.
Just Stephanie mentioned prehypertension and hypertension is currently one risk. Is that correct? And she would like for that to be separate. But I'm not sure that that's anything. I'm not sure we can change that, but I just made a note of that.
Awesome. Yeah. What about room 3?
Hi, I was facilitating room 3, and I will just say that, yeah, there was some surprise that how the risks are determined, you know, coming from USDA versus the state. And there was a rich discussion, and lots of great thoughts were shared. So please, group 3, share, someone.
I took notes so I can share at least a couple of the things.
Great, thanks, Laura.
Not so much, we had trouble sticking to the questions. So it was a great discussion nonetheless about, you know, things like low birth weight or things like that following somebody for 2 years, when actually it might rectify a lot sooner than that. So they're staying at high risk for a longer time possibly than needed. We also had the one about separating preterm and early term, because those were broad spectrum and they need to be a little more nuanced. Bit of frustration with the drug nutrient interaction one, that a lot of people aren't really even sure what to do with it. RDs have the most experience with it, but it's just more training was definitely the thought process there. A little bit of frustration with the lack of child weight loss as a risk, and also lack of women's reproductive health issues like PCOS and things like that not being in there, things that would be nutritional concerns.
All right, does that cover it, group 3? Do we?
Anything else?
Yeah, That's great. And for groups 4, 5, and 6, if you have anything kind of that hasn't already been shared or talked about yet, that's especially what we would love to hear. We're running a little bit behind schedule, but still want to hear from each group. So yeah, group 4.
I'll just go ahead and jump in. We didn't have a volunteer. I would say that one of the things that hasn't been covered yet is, as far as the high risk goes, low weights or underweights when the height actually makes them a healthy weight. So that's one that maybe with the at birth, it's babies are measured incorrectly. There's no way of removing that. And risks that the group wishes were high, that PCOS would have its own risk because it's buried under another, and or just having a women's health risk in general.
And I'll jump in for 5. You guys get to hear from a lot of state staff today. I'll jump in for 5. We had a lot of agreement, so we got straight into those 2 things that are high risk that we wish weren't were low birth weight. It's one of the first ones that came up. We talked about some of the trickiness of like the general high risk, but maybe there's good note taking, maybe there's not. So we think it needs to be kept, but it can be kind of messy. Pregnancy at a young age, it's a bit tricky because it's not maybe necessarily a nutritional risk, but it's a social determinant of health. And so there's kind of some nuance there in terms of like how we use it. Some of these young women are in really good situations and they're eating plenty of healthy food, and other times they're in really challenging situations, in which case that would be more of the concern. But the fact that they're young isn't necessarily the nutritional concern. Asthma, as it relates to drug nutrient interactions as a high risk, it sort of would fall maybe under that, but asthma itself doesn't necessarily impact eating. And then things that are low risk that maybe should be high risk. We've seen that depression can really impact eating. And also, I think for professional discretion, we talked a little bit about food allergies, how some of them are really mild and don't interrupt daily life, and some of them can be severe or life-threatening. So a big spectrum there. Thanks.
Yeah, great. All right, group 6.
So I can jump in. I think I would just say we didn't really feel like we had enough time, but it took us a little while to warm up. But one thing that hasn't been mentioned yet is the idea that early postpartum, sometimes those low hemoglobins are just a reflection of the physiological change that happens when you have a baby, that you do have some blood loss, and so you can be identified as high risk when it's just a normal physiological process. And then something we have local use on that is not anywhere in the risk criteria, but we see it is young children who are having chronic constipation. And, as dietitians, we can help with that. And it's not identified as a risk. So we have it as our own local RD referral risk when you have, daily use of Miralax or laxatives. I would say that as a dietitian, the depression conversation is also one where we talk about it as how well is it managed, because lots of people have depression and anxiety. Sometimes they're managing it pretty well and they're eating pretty well, but those folks for whom it's not managed well and they're not eating well, then yeah, of course it's a good referral. But we've actually had to work with staff to not refer people that are, maybe they've had depression for a long time, but it's reasonably well managed and they're doing well overall in terms of how they're eating and taking care of themselves.
This has been great discussion. I really appreciate it. And we've gone through all of the 6 groups. Is that correct? Yes, okay. So let's dive in terms of how, and I am looking at the chat and we have some great conversations going in there, and we will circle back around to make sure we can get those addressed. And we will not sacrifice discussion for content. So as presenters, we'll try to keep it as concise so we can jump back in for more discussion. So moving on, I'll practice that. Just to let you know, just to give some what is professional discretion high risk. It is something that will be in the Otis data system that came with the data system. And as we've described, it will be those for who could benefit from a referral, but technically do not have that high risk distinction. And it's a great referral pathway to all of you. So we're also tracking as time goes on, and we'll show you what this looks like in the system is, can we use this functionality for how some of the agencies are tracking their own kind of high risk, and that includes medical formulas and formula warehouse orders. So we're looking at how this might fit with clinic operations as well, and more information will come on that. So what we did is we reached out to how this was used with other WIC programs. So in the Intertribal Council of Arizona, they use it when a participant's not high risk, but they feel that the participant would benefit from an RD visit, or the situation is outside of the staff scope. They just didn't feel comfortable addressing it. In Hawaii, they use it in the absence of high risk factors, but they wanted the RD to be able to follow up with the participant. And in Kansas, they use it when there's multiple risk factors that individually are not high risk, but have that collective impact of the health status of the individuals. An example that they provided us was pregnancy at a young age, with homelessness and an abusive situation. So Oregon, being Oregon, we knew we wanted to expand this to our health professionals and have it be for breastfeeding experts as well. And that looks different in across the state. Some agencies have an IBCLC, others have a breastfeeding expert, or they refer to the dietitian. And we are working towards that designation of a DBE, a Debbie, a designated breastfeeding expert. We just knew that we needed to be flexible as each one of the local agencies is different. And we went out and asked local agencies to share examples of the referrals. So an example that Mary Kay gave, because Multnomah County was one that shared their policy with us, is chronic constipation. We asked Salud, Washington County, Multnomah County, and then Warm Springs. Kathleen Bucks provided some information. And these are what came up: special formula, the constipation issue, food allergies that restrict a major food group, children on a vegan diet that is a really restrictive diet, BMI that's greater than 90%, a rapid change in growth velocity, whether that's up or down, prematurity, and I've seen that a little bit in the chat, history of cancer or intrauterine growth restriction is in there as well. So with permission, we'll reach out to these agencies to see if these would be examples that they would be willing to share out to the larger group, and we can load them up to base camp if they provide us that permission. We also knew that PDHR recognized the impact of social determinants of health, something that we know that risks right now don't clearly support. They don't always recognize it. So there's a term called allostatic load, that there are risks that can pile up. There are conditions, there's the environmental, all of the aspects of what can contribute to the social determinants of health that can contribute and has not only an impact on the first pregnancy, but it can have a cumulative impact on future pregnancies. And that those social determinants of health, such as living conditions, access to health care, transportation, social supports, employment, money, they influence 50% of the health outcomes. It's, not even behavior, it's what they are just immersed in. And that by addressing those social needs, we can impact that individual, but also the family and future generations with improving health outcomes. So the PDHR is really a pathway, a referral pathway to address the social determinants of health, whether and we're doing this, a lot of this now, is those referrals of food security, transportation, targeted referrals, whether that be for substance use, mental health, housing, domestic violence, and that we're bolstering social supports during really key sensitive periods of time. So that breastfeeding peer counseling is a perfect example of just being able to help support and lift up and build resiliency for the family. And I have a case study here that this is real. I have not doctored this at all. And I just wanted to highlight what this could look like. So this is a case study where the family enrolled in WIC when the first child was 3 years old. Reportedly, there was an early term delivery, but the birth weight was 6 pounds, 4 ounces and 19 inches. So by the time they enrolled with WIC, the chart was pretty much unremarkable. It was just kind of like you look at it and they're sugar sweetened beverages. They were focusing on healthy food choices. And then along came the second pregnancy, and mom at this point was using meth. And after delivery, there was a court-ordered rehab. Mom went to live with family and was needing a medicated patch. In the notes, they talked about it as a Norco patch to help with withdrawals. Mom had started off breastfeeding and really wanted to breastfeed. But there was some latch issues, and she was concerned about this patch. So she would pump and then dump, and then eventually the breastfeeding gave up. Mom doesn't have any supplementation. She did not have prenatal care, heavy smoker, 10 to 12 cigarettes a day, and sometimes around the kids. And then the relationship issues. The dad took the kids for a visitation and then failed to return them. And now they're in a custody dispute with DHS involvement. Housing for the family is unstable, sometimes with family, sometimes with friends. There were red flags on the feeding, both early on. The staff was just really encouraging skin to skin as much as possible. Mom had gone through a C-section and had, things just did not go well with that early feeding experience. So then there was some concerns that just the parent-child dyad going on with the baby being fed, propped with a bottle in a car seat. So the second baby, 5 pounds, 10 ounces, so even lighter weight with slow weight gain, but just not enough to trigger the high risks because 5 pounds, 10 ounces, it's below that risk 141 of that cutoff at 5 pounds, 9 ounces. And there wasn't a weight loss. It was just a really slow weight gain. So they just were flying below the radar, and yet the risks were many and they accumulated. And what I've done here is the risk that you see is in dark, those were risks. So, put into chat what you think the risk level was for mom or baby the second time around, because it was low for the child, it was medium for mom, and medium for the infant. None of this was high risk, even though there's lots of environmental situations going on, a lot of stress within the relationship. Mom's doing her best, but there's a lot of factors working against her. Fortunately, the clinic did a great job of referring on to the dietitian, but you can start to see where some of our risks can have a very complicated situation, but just doesn't get caught. And what happens with the next pregnancy? Does that, as this goes on, this just has that wear and tear on the body, and it has health consequences both for mom and for the children. So I'm going to pass it over to Kelly to talk about the breastfeeding risks and have that conversation.
Great, thanks, Cheryl. It's kind of a good lead in, I think, but let's have to digest that, take a moment to take that in. So hello again, I'm excited to have this opportunity to talk with you briefly about PDHR and its potential role for providing a referral pathway for breastfeeding challenges and related risks. So in the next few slides, we're going to explore some breastfeeding challenges, some of those risks, 602, 603. We invite you to think about how PDHR may be useful as a referral pathway. And as we go through the slides, think about situations that might come up for parents during a prenatal or a postpartum visit, because I think sometimes, again, we're public health, we're prevention, and we can do a lot prenatally to get breastfeeding off to a good start, maybe catch some of those risk factors that would benefit the parent to see someone with some lactation expertise. And then I just want to, acknowledge that often WIC certifiers become aware of potential or actual breastfeeding challenges during a certification visit when they are busy and needing to get many things done as part of the cert visit. So if a referral pathway is not established, these challenges will oftentimes get missed, leading to lower breastfeeding, less breastfeeding. So in 602, you can see the risks, and these pertain to the mother, and so these are some of these are fairly common breastfeeding challenges that fall under risk 602, but because they do not fall under high risk category, parents may not get referred to an RD or other staff with advanced lactation training and skills. So again, PDHR kind of opening that up to those other skilled staff skilled in breastfeeding, and these risks can lead to potentially serious breastfeeding challenges for sure. So, so just take a moment to look at those. And currently, we do not have a consistent referral mechanism for breastfeeding challenges because our only required referral pathway is for high-risk conditions referred to an RD. So we think that PDHR may be a solution by providing that consistent referral mechanism to an individual trained in lactation. And so when you look at these risks, which of these often need quick help? And you could type that into the chat. Which of these do you think, if the parent isn't helped, may lead to some serious breastfeeding problems? Cracked, bleeding nipples, yes. It's very hard to, mastitis, severe breast engorgement, mastitis, yes. Yes, even plugged ducts, yeah. So I think you get the message here that probably all of them. Yeah, delay of milk coming in by day 4, we need some help. We need some help. That could probably be worked through. However, that parent does need some help. So yeah, thank you for that. Thanks for entering things into the chat. Appreciate it. Okay, I think we're ready for the next slide. So again, 603, these pertain to the infant, complications for the infant. So we have a few listed here. So with breastfeeding dyads presenting with these challenges, benefit referral for lactation help? Yes, I think so. How urgent are these situations? Are these urgent? Any that you see that are urgent? You could type into the chat. Yeah, jaundice, a lot of times things will, all of them, they really are. These are all things that we want to make sure that parent's getting some good help. And certifiers can oftentimes, they're trained in some basic breastfeeding, and they oftentimes can address these, but they may not always be able to do that, depending on, again, their skill level. So in our current breastfeeding training module, which is out of date and is going to be replaced soon, we refer to these as red flags. And then in our remote training that we've been doing, our breastfeeding basics, we use the term yield. So yield and refer can kind of be used interchangeably, but with yield, we sort of introduce that with peer counseling. And the idea of yield is that certifier or that peer counselor who's helping that family isn't just going away, they're actually bringing somebody else on board, and then continuing to support that family. So it's not just a handoff, it's actually, getting more people involved that have the expertise. So risk codes 602 and 603 are important, yet are not consistently chosen. as risks during WIC appointments by WIC staff. And so we just want to take a moment to just encourage WIC staff to please add these risk codes when they see a participant presenting with them. And why is that? Why do we want to do that? I think it's important that we track participant health needs so we can better serve our participants, for one, because I think we've all agreed that these are issues that if the participant does not receive help, if the parent doesn't get that help, it could lead to less breastfeeding and maybe even end of breastfeeding. And also, just if we can start tracking these and pulling these up in reports and seeing how often they're identified, that's going to help us identify some staffing needs. So do we have the staff to address these issues? Do staff need more training? Do we have staff trained to help with this? So I think it's important for a variety of reasons. Okay, Cheryl, I think we're ready for the next slide. And then there are just some other situations, right, where parents can benefit from more help. And the first two in particular are pretty common. And I would like to just draw our attention to the second one, because we see this a lot, wants to supplement with formula or stop breastfeeding due to complications. So that complications word there is key, because oftentimes, a certifier with has gone through basic breastfeeding training can really help do that assessment and help that parent with the breastfeeding. But sometimes it might be beyond their skill level. So, and it might really require that somebody else with more expertise gets pulled into that. And I'm sure that that is happening some of the time, but we just don't have that consistent mechanism. And I do see a question from Jennifer. Oops, I missed it. But yes, there are some things that are going to be built into Otis that will help us with that. So in the next slide, let's see, where was I? Okay, and sometimes it might even be that it might be a referral to an IBCLC in the community if there's no one in the agency that has that level. There is a requirement that every agency has at least one staff person with some advanced training, and we've been really working on helping get that training available. So that is the breastfeeding coordinator at this point, and it might be a few other staff as well. So in this next slide, you'll get to share how your agency currently handles these situations, because I know there's probably a variety of things that are already happening. And if your agency does not have a process for this, please, you are not alone. That's why we're talking about, and that's why we're excited about the potential of PDHR. We think that this is an opportunity to kind of just, to get that referral pathway set up so that we can help those families as best we can. And so, and I'm going to turn it over to my job share partner, Korina, Skaff.
Hi, thanks, Kelly, for that introduction. The poll question, Laura Purdue put it in the chat. So if you can go over to the poll question and open that up. And the question is, in your agency, who assists parents with complex breastfeeding challenges? And then the second part of that question is, and how do they get referred? So who in your agency assists parents with complex breastfeeding challenges, and how do they get referred? If you want to go ahead and move over to that.
Yeah, it looks like Cheryl is pulling it up right now. So we'll see people's results in just a minute.
Thank you.
Let me know if you need help, Cheryl.
Can you see it?
No, we are still seeing the PowerPoint.
Okay, let me stop sharing and bring that one up. I've got it.
This will give you some time to think about, well, who do we refer to and how does it work? Oh, look, we've got some answers. In your agency, who assists parents with complex breastfeeding challenges and how do they get referred? IBCLC gets a lot of IBCLCs. We've got breastfeeding counselors, IBCLCs, RDs, and then there's some referrals into TWIST and breastfeeding notes and callback. That's a great report that you can pull up in the breastfeeding tracking section of TWIST. They might get a refer by email or direct message to the IBCLC. WIC ID emailed to IBCLC.
And there are a lot,
then,
there's a lot
go
more
ahead.
coming in on my screen, Cheryl. I'm not sure why they're not moving on your screen.
There's a lot more. Do you want to go ahead and state them, Laura?
Let's see. Yeah, let's. I mean, it's a lot of similar ones, a lot of IBLC.
Okay.
So we'll make sure to share this out with everyone afterwards as well.
So I appreciate you all sharing. Wow, you all do so much to support our Oregon families. Thank you for your efforts in helping WIC families find the breastfeeding support they deserve. And as Kelly said, hopefully PDHR can provide a consistent referral mechanism to help us in assisting WIC families with their breastfeeding needs. So thank you for this. All right.
Thank you, Korina.
You're welcome.
All right, Erica, take it away. The nuts and bolts.
Yeah. Yes. So we did want to give you a kind of a sneak peek on some of the screens in Otis and how PDHR is assigned. So what you're seeing here is a screenshot of the risk assignment screen in Otis. And you'll notice that there's a bunch of risks that are listed, and it's similar to TWIST where you can double click them, or you can click them and use one of the arrows in between to move them to either column. And the pink looking ones are the high risk. So that's kind of nice that we have that in Otis. And to add PDHR, so first you would want to make sure all the risks, the appropriate risks are assigned, because if someone is already high risk, we would not assign PDHR. So making sure all applicable risks are assigned. And then if there are no high risks, you can see the teal arrows that kind of show the add button. And then a line would be added in that professional discretion high risk section. So if we go to the next screen, once you click add, this box comes up, and that little red asterisk is how we indicate a mandatory field in Otis. And so you have to put a reason for PDHR, and it would then show up in that PDHR box at the bottom of the risk assignment screen. It may also show other places. We haven't been able to look at the demo site again recently, as Cheryl said, but yeah, it will at least show there. And you would want to enter the reason here, and then also a progress note. The next slide shows what happens once someone is assigned PDHR. At the top of the screens in Otis, where it has, their name and other info, it'll have PDHR in red. And that's also where high risk would be indicated, which I believe is HR. And so, it is possible that someone might end up having both designations, like if they are initially a PDHR and then something comes along where they are high risk, they might have both. But the intention with assigning PDHR is that there isn't a pre-existing high risk there. So the pathway on the next slide. So yeah, just kind of a overview of the pathway. So selecting all applicable risks. If you feel they need to see someone, dietitian or breastfeeding support, and then you would need to add the PDHR, you would add the reason, also hopefully adding a progress note. So whoever you're referring to would have a bit of the backstory that you've already gathered, and then making the referral in whatever way your local agency does that. And then the only time PDHR will be required is with risk 201. So we were hoping that when we launched Otis, risk 201 would be separated into 201A and 201B automatically, but we didn't get that in on this first version. So it'll be a little while before those are split out. And so if there is a very low hemoglobin, the 201B, there will need to be PDHR assigned. So that will be something that state reviewers actually are reviewing for. But the other uses of PDHR wouldn't necessarily be something that's included in a biennial review. So this is hopefully a short-term plan because risk level in TWIST, we can adjust the risk level, and this is the only instance where we do right now. But in Otis, the certifier won't be able to just bump up the risk level to high. So that's why PDHR would need to be assigned in this case. And the referral to the dietitian is required within 1 to 2 months, same as what we've had in policy up until now. So yeah, and then the other thing that with hemoglobin that it doesn't automatically do is the altitude adjustment. So for those local agencies that that are at a higher altitude, that still will be a manual thing. And so that will still need PDHR even once we have 201A and 201B split out. The system still won't be accounting for altitude as far as we know. It's similar with cigarette use with the amount that would affect hemoglobin. So those are still things to kind of keep in mind, but hopefully for a lot of local agencies, if they're at lower altitudes, the split between these two will make it so that we don't need this workaround for forever. Okay. I think we're ready for breakout groups. I'm trying to cruise through it, but hopefully not going too fast, just to make up some time. So we're going to go back into breakout rooms, and there's a lot of questions that we have. So, you know, your group might just focus on 1 or 2 of them, but see what we can get through, because we really want to know what people are envisioning after having this bit of an overview of what PDHR is, kind of as your wheels are turning about how this might work in your local agency. And also, if you have any feedback about the parameters around, like, once someone is designated as PDHR, then what? Like, how many follow-up visits would they need to have with either the breastfeeding expert or dietitian? So there's just some other questions about that, just the considerations as we continue to formulate our PDHR plan.
Erica, I like the flexibility you built in there, because it really is just, if you have questions, that you have time to be able to kind of process this. So Laura, when you're ready, go ahead and put us in. And we're going to do a 10-minute breakout, which I know is even shorter than last time, and we apologize, but we also want to honor your time. So take it away, Laura.
All right, moving you now.
HR, a total for both of those. So it just gives us a snapshot for each local agency.
Which is great when you want to capture the good work you're doing.
And hopefully advocating for more RDs.
Absolutely.
Exactly. I was just thinking of your question with that, Island. Yeah, definitely. Yes, it would be great for that too. So Cheryl, are you wrapping us up here?
We are. So there is a link that we will, that's on the slide, but I will copy it over to, or Laura Purdue can put it in the presentation. We really want to hear from you, both in terms of the information that was shared today, but also any suggestions for future meetings, what topics you'd like to hear. The next steps for PDHR is we're going to take all the information that you've shared, both on risk level, but also on the PDHR specifics, and we will revise our policies to reflect the discussion. We're going to continue development through 2022. Our pilot agencies are Deschutes and Crook. So welcome back to work, and Christine. And then we will continue to assess and adjust as needed. And I really heard from our group that flexibility with PDHR is going to be key, and that referrals is the real key, that we want to make sure that it gets done, whether that's by email, by text, by the scheduling. And I just want to thank the team for the contributions that we made today. And we are 1 minute over. And I can't wait to show you more with Otis. Can we have more meetings on risks? Oh my goodness. Kathleen, you guys are the best group. Yeah, we will build in more time for risks. Why not? So thank you so much for everyone for joining, and you have a great afternoon, and keep the comments coming, whether you just we can keep the chat open, or we can just contact your assigned nutrition consultant. But we really want to hear from you, because it's only going to be as good as the feedback that we get from the end users. And so we really appreciate your contributions. Have a great day, stay cool, and thanks again. Yeah, please share in the survey. We got that going. So we want to hear from you. Thanks, everybody.